Welcome to the Moss Report with your host, Dr. Ralph W. Moss.
Hi, welcome to the Moss Report podcast. This is your host, Ralph Moss. Today we have a very special guest, Dr. Dipnarine Maharaj of Florida. Dr. Maharaj is the founder and medical director of the South Florida Bone Marrow Stem Cell Transplant Institute, which is also known as the Maharaj Institute of Immune Regenerative Medicine. And he also is the director of the Stem Cell Cryobank. He has amazing medical credentials. He got his medical degree from the University of Glasgow Medical School in Scotland, which is a world-famous center for medical education. And he completed his internship and residency in internal medicine and hematology and fellowship training as a hemonc, a hematology oncologist and bone marrow stem cell transplantation expert at the University of Glasgow Royal Infirmary in Scotland. From there, as he will tell us, he was recruited to come to the University of Miami, Jackson Memorial Hospital, and the Sylvester Cancer Center to establish their bone marrow stem cell transplantation program. But since then, he's been on his, have his own clinic in South Florida, and he'll tell us what they've been doing there. I have visited with Dr. Maharaj at his clinic, a lovely occasion that we had some years ago, and we talked about then emerging field of stem cells, which has now come a long way. But what got me to want to have him on the program at this point is a paper that he and his colleagues have written about the cure or complete remission of a woman who has CLL, chronic lymphocytic leukemia, which is not a diagnosis that one often thinks of as being curable. So something remarkable happened with that, and I want him to tell us. So welcome to the podcast, Dr. Maharaj.
Oh, thank you very much, Dr. Moss. It's a pleasure to be here, and thank you for having me here this afternoon to be able to to chat with you and to answer questions about our patients and the work we do.
Yes. So why don't we start out, go from the specific to the more general. What happened with this patient? And there could not be very many cases in the medical literature of people with CLL being cured of the disease. Could you explain to us about that case, about that woman, and exactly what happened?
Yes. So this was a middle-aged woman. She's actually in her mid-60s and had been diagnosed at least about 10 years previously with chronic lymphocytic leukemia, which, as you know, accounts for 25% of all leukemias worldwide. But as is often the case with chronic lymphocytic leukemia, because of the word chronic, it's often basically patients are told they have the diagnosis, and that usually it's most of the time the treatment for it is watch and wait. And actually that's what happened in this patient's case. She was treated by her local hematologist, who said to her, "You have a high white cell count, you've got some lymph nodes which are enlarged, we'll just watch and wait." And that was around 2012. So sort of for the first between 2012 and 2014, it was a watch and wait. She was seen every 3 months. Her blood counts were checked. But in 2014, something different happened. She began to develop lymph nodes. Her white cell count started increasing. And at that point, she also began to become anemic. So clearly, the disease was changing its course. She was put on one of the newer drugs for treating chronic lymphocytic leukemia. It's called ibrutinib. It's classed as a targeted therapy. So she was put on it. The outcome she had was that she responded to the treatment well, but within about a year or two, she actually began to actually develop a severe skin rash from it. Now, I saw her uh, after she'd been on it for a year in around October of 2015. And I kept her on it because she was doing well. Her counts were controlled, the lymph nodes were controlled, and our evaluations suggested that she had the sort of typical, CLL with some mutations, and so she was responding well. So we didn't really change anything, but around January of 2016, what happened was that her disease began to progress, and at that point, what was more significant, though, was the fact that she had developed a very severe skin reaction to the ibrutinib, and she basically said at that point she wanted to come off of it because it was the rash that she had was on her face and her arms, and they looked quite. There was really quite severe, so she had to be treated for that. She came off the medication. Um, Interestingly, when she came off the medication and we continued to monitor her, her counts stayed in the normal range. And it stayed like that for about a year. But then at the beginning of end of December of 2016, early January 2017, at that point, her disease progressed. And so we did a complete re-evaluation of her disease. And what we found was that in fact, she had genetic mutations, some of the very severe mutations associated with a poor prognosis, chronic lymphocytic leukemia. So at that point, we had a discussion with her about the types of treatments that would be available for someone with this type of poor prognosis leukemia, which included chemotherapy, included chemotherapy such as fludarabine, cyclophosphamide, bendamustine, rituximab, other anti-CD20 monoclonal antibodies, and all of these. With these treatments, the idea was that basically give her the best treatments that would be available to treat her CLL. However, she was very averse to any type of side effects. So other targeted therapies, including venetoclax, idealisib, and we even discussed with her a bone marrow transplant because she was young. We also discussed with her the experimental types of treatments, including CAR T cell therapy, or the alternative was no therapy or experimental therapy, which we have been working on at our institute with low dose immunotherapy. So all of these options were given to her, but she, being again having suffered severely from the side effects of the ibrutinib, she said she really wanted the treatments that would give her the least side effects, because with her disease and the understanding that this is a disease with a poor prognosis, she wanted to be treated with, not to be have a lot of side effects, poor quality of life, and also not sure about the benefit of the different treatments in terms of prolongation of her life.
Mm-hmm.
So it was at that point I introduced to her the idea of the novel approach which we have been using, which would be basically we would identify a targeted therapy to her mutations that we identified in the cancer, and then at the same time measure her immune system, looking in detail at the specific abnormalities of her immune system. The goal would be target the tumor cells to actually destroy the cancer cells, but at the same time not damage her immune system. And in fact, by measuring her immune system, we would look for the evidence of recovery of her immune system. So she agreed to that approach. And so what we did was we started her in February of 2017 on a low dose immunotherapy protocol using low dose IL 2, interleukin 2, as well as low-dose Revlimid. Revlimid has been shown in patients with chronic lymphocytic leukemia to be able to improve and correct the T cell defects, as well as down regulating T cell inhibitory molecules, and it induces also natural killer cell expansion and activation. So that was one of the major approaches by using the Revlimid or lenalidomide at a lower dose. It has these anti-tumor effects, and at the same time, stimulating her immune system. So we were not going to do any damage to her immune system, but we were actually just basically going to stimulate it.
So the Revlimid, just to explain, is a derivative of thalidomide, right? Or maybe a version of thalidomide, which for older people might recall the name because that was like the most notorious drug scandal, I would say, of the 1960s, when it was discovered that women who got that drug as a sedative, then if they were pregnant, they gave birth to deformed babies. And that happened thousands and thousands of times across the world, but not in the US. And that's what gave rise to the 1963 reforms of the Food and Drug Administration to make sure that that never happened. But surprisingly, it came back, right, as an anti-cancer medication back
Yeah.
in 20 years ago or so, and became one of the top, in fact, the top selling cancer drug in the world at one time, because it's so effective in multiple myeloma and in some forms of leukemia. Am I correctly
Yeah,
summarizing that?
absolutely.
But
And
what confuses me in this idea, I don't find it hard to believe this at all, but um, so CLL is a disease of the lymphocytes, right? And
yeah,
the B cells or the T cells. And you're saying that in this case, it was affecting her T cells. Is that what I was hearing?
no, no, it was
No.
actually affecting
Oh,
her B cells, and
which
in
would be
fact,
more normal, right? I mean,
yeah,
for CLL. So I guess again, I don't have any trouble conceptually with this, but I think what a lot of people would be wondering about is you're giving substances like the Revlimid and like the interleukin 2 that stimulate the immune system, and here you have a patient whose cancer is characterized by an excess of lymphocytes. Aren't you in danger of overstimulating the immune system in a situation where I'm playing the devil's advocate, but in a situation where um, you already, with the basic problem, is an excess of lymphocytes or these special kind of white blood cells. So explain that, how that works, or why you feel comfortable or safe in doing that.
yes, no, that's a very good question, because when we think about cancer, basically, um, the issue comes back down to B cells. B cells should be, which are part of the adaptive immune system. So, just to explain that in a little bit more detail, with the immune system, there are two components. There's the innate immune system, and then there's the adaptive immune system. The key cells in the innate immune system are natural killer cells, but there are also neutrophils, monocytes, macrophages, and dendritic cells. That's the innate immune system. And then within the adaptive immune system, there are B cells and T cells. So your question is really a very good one. That is that. So here we have somebody who's got a B cell chronic lymphocytic leukemia that has got an increased level of B cells, and therefore, if we begin to treat her by stimulating her immune system, are we going to make her disease worse? Are we going to increase the actual number of B cells? But the issue is, the reason why the patient developed the cancer in the first place is because of the defects of both the innate and the adaptive immune system. So let's go into that in a little bit more detail. In patients with chronic lymphocytic leukemia, there are abnormalities of the innate immune system affecting their neutrophils, affecting the function, the function of their neutrophils, of their monocytes, of their dendritic cells, and also of their natural killer cells. So all the cells of the innate immune system are abnormal. In the adaptive immune system, what you have is a clone of B cells which are abnormal, which are essentially non-functional, except that what these abnormal cells do is that they secrete proteins, which actually suppresses the other components of the immune system. And similarly, you have the T cells, which are the function of the T cells within of the adaptive immune system in patients with CLL. Their function is also suppressed. So you can look at these cells, look at their numbers, but when you actually look at the function, the overall function of both the innate and the adaptive immune system of these patients, it's abnormal. So therefore,
you have a greater quantity but a worse quality of the
yeah,
overall immune system.
correct, yes.
You'd think you'd have a better immune system. You've got so many B cells around, but it isn't. It doesn't work that way because, as you said, they're not normal. But don't they sort of look normal? I mean, under the microscope. I mean,
Well,
the
morphologically, they could look normal,
uh-huh,
but
uh-huh,
in fact, one of the characteristics under the microscope of these abnormal CLL cells or B cells is they're called smear cells. So they easily, when you smear the blood smear to actually prepare it, they're smudged. They look like smudge cells, and so
mm,
they're clearly morphologically abnormal. But if we look at them using flow cytometry, then clearly you see that these cells are abnormal because in chronic lymphocytic leukemia, it's a clonal expansion of B cells, which particularly affects the B cell antigens CD5 and CD23.
mm,
That's what allows us, when we make the diagnosis, to be able to say that these are abnormal cells, abnormal B cells. And again, to re-emphasize, there might be lots of them, but their
mhm,
function is abnormal.
mhm. So basically you gave the woman's in her 60s, right? Is
Yes.
that what you said? And you gave her now two. I heard two things. So one of them was the uh, interleukin, the low doses of interleukin 2,
Yes.
which people we should explain. So interleukin 2 is one of the first cytokines or messenger chemicals produced by the immune system that was approved actually by the NCI back in the 1980s as a treatment for kidney cancer and melanoma. It was an early form of immunotherapy, but given at the NCI, National Cancer Institute, given in such high doses that as somebody once said to me, it peeled the paint off the walls. I mean, it was so toxic that even though it was somewhat effective, but nobody else other than people at the clinical center at NCI, almost without exception, they didn't want to use it because it was just too toxic. Am I right?
Yes, absolutely, and I think that that's one of the main reasons why it's not used because at the dosages that it is used, um, it is very toxic. It leads to a condition at very high dosages. And just to give you an idea,
Yeah.
put it in perspective,
Yeah.
for a patient, interleukin 2 is approved for patients who have renal cell cancers and also patients with melanomas.
Hmm.
But the standard dose is usually over a 3-week period as an infusion. And the dosage that's used is like 126 million units per
Hmm.
day,
Hmm.
given over a 3-week period. The dosing that we use is basically low dose. And if you take a fraction of that 126 million and you say it's closer to between zero point 0.4 and 1 of that 126 million, that's the percentage that we're using of the low dose.
Did you
Now,
say 0.1?
zero point 0.4 to
Uh,
1
oh, it was 0.4 to
of,
1. Uh-huh.
of that total
Uh-huh.
dose that we use. So this
Uh-huh.
is This is a very low dose, and
Right.
therefore toxicities are very low, and in our experience, extremely low. Now, there's an even lower dose, which is called an ultra low dose, because I'll explain to you what many doctors who, when they read the literature, and when I have patients who are on the treatment and they go to their oncologist and their oncologist look it up, they'll say, "Oh, but this is IL-2 is very toxic, first of all. Secondly, that it stimulates regulatory T cells." So I need to explain that a little bit more.
Yeah.
When on the T cells, within the compartments of T cells, there are certain T cells called cytotoxic T cells, which are marked as the CD8 cells. Within the And these are cytotoxic T cells which we want to stimulate to kill, and their effect is to kill cancer. In
Hmm.
an autoimmune disease, they're overactive. In patients with cancer, another type of T cells called regulatory T cells
Yes.
are low.
The Tregs.
Yes,
Right.
the Tregs are low.
Right. Yeah.
So what some people say is, well, if you give low dose IL-T, you're going to stimulate the Tregs, which basically means that you are now blocking the effect of the cytotoxic T cells, the CD8 T
Right.
cell, to kill the cancer. But in our protocol, because we do a very precision approach, where we measure the B cells, T cells, and natural killer cells and the different subsets and the natural killer cell function, what we have found is that by varying the dose and frequency, we can get the natural killer cells function to increase, which are natural killer cells are part of the innate immune system that directly kills cancer cells. And we can also increase the CD8 cytotoxic activity, but without increasing the Treg activity. So that's how we're able to, by measuring, make sure that the dosing we're using is able to target allow the specific cytotoxic T cells and natural killer cells to target the tumor, but not increasing the regulatory T cells.
So that dose, that dose that doesn't increase the Tregs, is that the 0.4 to 1% dose, or is that the ultra? You started to talk about the ultra low dose, which the dose you're giving is in that range of 0.4% to 1%.
It's about there.
Mhm.
But again, the other thing that we have found is that because it's almost like we titrate the dosing to be able to, when we measure the Tregs, when we measure the natural killer cells, the dosing will vary depending on the patient as well.
Mhm.
So
Mhm.
we're using that as a range just to compare what the dosing is versus what the standard dosing is that is approved for patients who receive IL-2 infusions. So I just use that as an
Yeah.
example, but that ratio that I gave will vary from patient to patient.
Sure. And with the standard dose of IL-2, the thing that people feared the most was the vascular leak syndrome or the capillary leak syndrome. Do you want to describe that, and do you see that with your patients when you give the dose you're giving?
Yes, no, we don't see that. So the capillary leak syndrome is basically where patients who are on high dosages of IL-2 can get pleural effusions, they can get pericardial infusions, they can actually get tissue collection of fluid, because essentially what's happening is the IL-2 is going to the cells, the endothelial cells, in the blood vessels, small blood vessels, and there are receptors for IL-2 on that. So it actually causes dilatation of these cells, which then causes fluid within the capillaries to leak out. And if it occurs in the lungs or it occurs in the heart, there can be severe side effects associated with that. But
The legs can swell up, and you can't really do anything about it because it's sort of an
exactly, that's correct.
irreversible process.
Yeah.
So I think that's the reason that despite uh, despite Dr. Rosenberg's enthusiasm at the NCI for IL-2 therapy, why it kind of died out was because doctors didn't know what to do with a situation like that. But
Yeah.
it's odd that instead of it's just odd that nobody debated really that there were these responses in very advanced disease using IL-2, but they kind of threw out the baby with the bathwater, right? Because once they realized that of the danger that existed with interleukin-2, it's instead of saying, well, let's keep lowering the dose to the point where we get the benefit, they just sort of gave up on it and went on to the new thing instead of preserving that, all except at the NIH, at the National Cancer Institute, where they have continued to refine that sort of treatment with some success, I would say. So, but the mainstream of oncology kind of moved on, and now, of course, with the rise of the immune checkpoint inhibitor drugs, nobody's interested anymore, basically, in IL-2. But you have sort of found a use for it by using, well, the first do no harm principle. In other words, use the least toxic treatment that could possibly be effective. It seems like that's what you've done.
Yes, I mean, my goal has been, as a bone marrow transplant physician, essentially, I'm trained to be able to give ablative dosages of chemotherapy and support a patient through that process, and then get them through the procedure, and then we have the patients recover. The issue is that with when you treat patients like with high dosages of chemotherapy or even standard dosages of chemotherapy, toxicity is something we sort of take for granted that it is going to occur. But I felt that to be able to improve the field of cancer, we had to be able to find ways of being able to go after the specific issue that caused the cancer in the first place, and then understand the defects within the immune system that's causing the cancer and allowing the cancer to progress. And if we can target that, which is basically what our approach was here, we could minimize the toxicities of the medications, the drugs which are effective, but at the same time have the patient have a good quality of life and reinstate the immune system, which was damaged and what caused the cancer in the first place. So that's the approach that I've taken. Is to basically say, we can do bone marrow transplants and we can do standard dosages of chemotherapy, but how can we improve the outcomes by achieving types of remissions like this, which is we were able to achieve a molecular remission without a bone marrow transplant, but giving treatments which targets the immune system to restore it and with minimal toxicity.
It's extraordinary achievement. Really great. So how is the woman doing now?
She's doing very well. We were able to, using this approach and turning her immune system back on and getting a natural killer cell function, cytotoxic T cells to begin to work again by secreting gamma interferon and TNF alpha, which are the cytokines that actually are key in terms of killing cancer cells. We were able to get her into a molecular remission where the IGVH mutation, we could no longer detect it. And so by December of 2019, we were able to achieve that. And so since then, she's had regular follow-ups and she's doing very well. And she's leading a normal quality of life. And we continue to monitor her to look to see what her immune status is, and also to look for any changes in the mutations. But so far, she's been doing very well.
That's wonderful.
We would like to take a moment to thank our Patreon subscribers for helping to make this program possible. If you would like to have access to exclusive content, including transcriptions, episode recaps, and special offers, become a patron today at patreon.com/mossreports.
It's a really wonderful story. And of course, it's published in a peer-reviewed medical journal. For people who think that, well, this is just another anecdote, I just want to emphasize that there's a huge difference between an anecdote that you read about on the internet, somebody reporting what happened to somebody who they heard it from a third party, or even an individual reporting on their own case, because individuals are not always entirely accurate in recording their own history. And something like this, which is a case report in a good journal, Cells, December 2020, for those who want to look it up, and where everything is fully documented. So it isn't like some people would, denigrate this and say, "Oh, another anecdote." No, this is something else in a disease that's famously resistant to treatment, right? I mean, CLL, although it can smolder for more than a decade, but it's also extremely difficult to find reports of cures, other than perhaps sometimes with bone marrow or stem cell transplantation.
Yes. No, I mean, to put it in perspective, essentially, with patients who have this IGVH mutation, what we call the unmutated status, if you look at the projected survival of these patients, it varies between 1 to 9 years in the patients who have the unmutated status. But we were able to get this patient into a molecular remission. So we couldn't find abnormal cells that had that mutation. So if you look at the other side of it, the mutated state, the projected survival is often related to be like 17 to 25 years. So I think that that's one of the remarkable things in this particular patient's case. By looking and focusing on the specific defects within the immune system and targeting that, it worked, because the abnormal cells containing those mutations were killed off and disappeared.
So, is there any possibility of doing a clinical trial with this methodology? I mean, given the fact that you obviously at numerous points you're individualizing the treatment, how would you have a control? Well, your control group would be people who were either untreated or who were being treated non-curatively, right? I mean, so
Yeah.
but could you foresee a clinical trial? Do you think there'd be any interest in doing that?
I I would like to do a clinical study. I think that, um, and I'm sure many patients would be interested in this, because, again, remember, one of our primary objectives was low toxicity, and the second objective was maintaining the immune system, because many patients who have CLL, who are in the mutated state, that's the state where they have, they're told, well, let's watch and wait.
Hmm.
Even in that state, they have abnormalities of their immune system, so they still get chronic infections, and they're still affected by it. So I would love to do a clinical study where we could actually treat patients. We would, of course, treat the patients with the poor prognosis, the unmutated, first, but we could do, as a second group, the mutated state. Um, so, to the answer to the question is yes. If we could get enough resources, if we could get interested parties to work with us, the design of the study could be done in such a way that we could look to see, could we move this towards a way, as another way to be able to treat patients with CLL.
Yes, no, it would be the logical next step, because I don't think any number of case histories are going to change practice. But I think, even starting a clinical trial, I might get a lot of attention. I, if you wouldn't mind, I'd like to pivot to another issue that I think you're uniquely qualified to answer, and that is to talk about the role of stem cells in the cancer process. And I'm thinking particularly of the the very long-standing theory, which I would take now to be a fact, that a lot of cancers originate or let's say there's a hierarchy of cells within a tumor or within a cancer, and that the pinnacle of that hierarchy are this category of cells called CSCs, or cancer stem cells. Do you agree with that
Yeah,
theory or that
I do.
proposition?
No, I do. I agree with that. And
Uh,
the classic example of that is leukemia, acute
mhm,
leukemia. In leukemia, the leukemia arises in a cancer stem cell, a leukemic stem cell, which can be
mhm,
identified. And I think that acute leukemia was the first type of cancer in which a cancer stem cell was identified as the cause of the cancer. Since then, of course, there's been so much work in other types of tumors, breast cancer, colon cancer, other tumors, prostate cancer, which shows that essentially it's a cancer stem cell, which is basically the origin of the tumor. And I think that
Right.
the underlying process is that basically is related to aging and the aging of the immune system, because one of the issues of aging of the immune system, or immune senescence, is that the decline of the innate and the adaptive immune system, and particularly the decline of the natural killer cell function within the innate immune system, means that cells which normally target cancer cells, they're not functioning well. And so you have, initially with senescence occurring in every single organ, is you have a normal stem cell which undergoes mutations, which converts it to a senescent cell. And then further mutations that converts it to a cancer stem cell. And I think that that's one of the underlying ways now that we're understanding of the origin of cancer.
Mm-hmm. Mm-hmm. So this is profoundly important. I mean, in so many ways, because it speaks to the origin of cancer, and it establishes the principle of hierarchy. So, in other words, within a cancer, people in the past, many people thought of all cancer cells being equally bad or equally dangerous, and didn't see really any particular hierarchy or pyramid of danger or of need to counteract those cells. Um, but now I think we understand that I don't want to draw too much of a dichotomy between the cancer stem cells and the ordinary, the so-called daughter cells, but there is a big difference, right? Because a lot of the things we fear most about cancer seem to be ascribable to the cancer stem cells, not so much to the ordinary foot soldiers of the cancer, but to the ringleaders of the cancer. Is that
Yes.
accurate?
Because the cancer stem cells also have similar properties of normal stem cells. So if we look at stem cells within the bone marrow and use that as an example to relate it to other organs, within the bone marrow we have pluripotent stem cells which are quiescent. And
Mm-hmm.
within bone marrow we have two compartments. We have the reserve compartment, which is basically full of quiescent stem cells, and then we have the progenitor compartment, which is basically the cells that are further down the line, which then forms the cells of the immune system, innate and adaptive, as well as the red cells, white cells, and platelets. So a cancer cell can arise within the quiescent stem cell because of
Mm-hmm.
mutation occurring, and that cancer can remain dormant, and then it's when it turns on, it actually produces the progenitors, which we see as the cancer. But the quiescent cell, which initially turned on and goes back into quiescent, is the cancer stem cells. So we can treat the patient of the progenitor cells, and we think that the patient is now cured. But when the cancer stem cell, which is quiescent, turns back on, the disease comes back.
Yeah. So it's kind of a ticking time bomb. If
Yeah.
if you have a quiescent cancer stem cell, what about treating the cancer stem cells? I see so many references in the literature to natural agents like curcumin and EGCG from green tea, curcumin from turmeric root, and maybe 15 other food-derived factors that in the laboratory kill cancer stem cells. Do you have any thoughts on that or any hopes regarding that?
Yes, I think that there's good evidence. Actually, one of my scientific collaborators, Dr. Jewett, who we published together and we worked together in her lab, which is based at UCLA. She's actually been showing that by identifying cancer stem cells and the particular process we have used in our patient, she has also used in her lab as well. But there are certain types of natural killer cells, which are CD56 bright 16 negative. These natural killer cells actually secrete cytokines like TNF alpha and
Hmm.
gamma interferon. And they have the ability, and she's been able to show that by stimulating these and growing these types of natural killer cells, which are cytokine secreting, that they have been able to, in the lab, knock out the cancer stem cells. So the analogy then comes back down to the natural products that you've just talked about.
Hmm.
Because if you look at the molecular biology and the pathology, the way that these natural, let's call them spices or natural herbs
Hmm.
or
Hmm.
product work, is that they can also increase TNF alpha. They can also increase gamma interferon. And
Hmm.
I know it work because one of my scientific collaborators and close friends is Dr. Bharat Agrawal, who was the
Yes.
head of cytokine research at MD Anderson, and he actually
Right.
published extensively showing that these products actually at a molecular level can actually kill cancer cells. And I think that it's a further extension to be able to show that which specific cells of the immune system are actually killing the cancer stem cells.
Yes, and he's an old friend of mine, and I visited him at his laboratory when he was still at MD Anderson. Yeah, so this a it's right up your alley, right? I mean, you didn't know when you started out becoming a specialist in stem cells that because that the cancer stem cells would come into such prominence, right? I mean that's been a fairly recent development. Professor Dick at University of Toronto, I think, was the first one to show this in chronic leukemia, and it's just taken off like a rocket. I mean, the amount of research being done, and yet I talk to a lot of cancer patients. I've yet to meet one whose oncologist ever said to them, by the way, do you know that most cancers originate in cancer stem cells? Because there is no drug per se, in my opinion, no dedicated drug that's been approved for treating cancer stem cells. So it gets short shrift in the oncology profession. But I think the scientists know that this is the next great frontier. I expect as soon as the first drug comes about that selectively kills cancer stem cells, you're going to see a development similar to what happened with the approval of Yervoy for the with the immune checkpoint inhibitors. In other words, it opened the floodgates, and it'll be further confirmation of the role of the immune system in
Yes, no,
cancer, which
absolutely. I mean,
is
I think just to add to what you're saying, and as a bone marrow transplant physician, we would, do transplants in patients. We would get patients with long-term survival. And in fact, one of the reasons why I moved towards developing the work that we're doing is because we would often study the patients who were long-term survivors of bone marrow transplants. And when we looked at their immune system, you would see that in fact their natural killer cell function had reverted back to normal. And
hmm
so the way we would conclude that to explain to a layperson is that we had reinstated immune surveillance. So we have also had cases of patients with chronic myeloid leukemia who 20 years later were in complete remission.
hmm
And when we looked at the bone marrow, we could still find the Philadelphia chromosome positive cells there. So why would those patients not relapse? And the reason, and again, these cells are coming from stem cells that causes chronic myeloid leukemia. So the
yeah.
question is, the cancer stem cells are still there, but why did the patient not relapse? And the reason is because the patient's immune system had recovered and their immune surveillance had recovered. So therefore, the cancer stem cells were being blocked. That if ever they decided to sort of turn back on, the immune system would kill them. And that's, I think, what we have to be able to do. And what it's one of the reasons why we monitor our patient, in this case, in our paper, so closely, because we wanted to be able to again show the reinstatement of immune surveillance and why the patient's disease, has not recurred.
Well, it's brilliant work. thank you so much for coming on our show. I hope we can have you back again. There's so many more questions that I want to ask you, and I think our whole thinking, it so resonates with each other, and I'm sure with our audience. So thanks again, Dr. Maharaj, and I hope that many patients who are dealing with these diseases will come and see you. You're a clinician. You have a beautiful clinic in Florida, and it's just wonderful to get your insights. So, welcome. Thanks again for
Look,
your
you.
participation.
Thank you for having me on. It's been a pleasure to be on the program with you. I look forward to coming back again, and thank you for all the very detailed but very clear questions that you've been able to, you've asked me to be able to educate as much as we can, patients with cancer. So I
Yeah,
would like to thank you again.
good. We'll do it. Okay. Well, for the Moss Report, this is Ralph Moss.
Thank you for listening to the Moss Report podcast. Hosted by Dr. Ralph Moss and produced by Rachel Moss, this podcast is a production of Moss Reports. It has been made possible in part by our supporters on Patreon. When you become a Patreon supporter, you will have access to episode transcriptions, recaps, and more. Learn more at mossreports.com/Patreon. We thank you very much for your support.